Now, I'm going to ask a question, which I've got to tell you now that I can hear myself asking it, it's like, I'm old. And when I heard older attendings when I was young ask this kind of question, I said, hey, he's old. What was wrong with what we were doing? I mean, IV drugs, come on, Jim. Here we have oral drugs. How do these oral oncolytics compare to the parenteral drugs that were the only drugs, really, when I was growing up in medicine, in terms of use, in terms of access?
Well, so, the drugs that we traditionally have been using in oncology were IV drugs. And those drugs tend to have more side effects. There's also more administrative costs with those drugs. And what's developed more recently is the use of oral oncolytics, which is obviously more convenient for patients because they are in and out of the office less frequently. Generally, they tend to have fewer side effects. But it also brings up the issue of cost. And traditionally, the IV chemotherapies were covered under most insurances, whereas the orals were part of Medicare D in many cases. And that was a limitation to the use of those drugs because patients just couldn't afford the copays.
I want to drill down into that. We're going to get that covered a little bit later. It's important. Don't forget, we're getting back there. But in terms of patients now, in terms of acceptance, it occurs to me if I'm a patient with a tumor, with some sort of hypermitotic issue, and you can pick the tumor you like, it's a big difference for me if I can go home, take a pill, or if I have to go to an office, get hooked up to an IV, get an infusion for a day, take a day off of work. The oral oncolytics seem as a class to be just that much better for patients.
Yeah, I mean, cancer has become a chronic disease. Patients are on treatment pretty much for many cancers, not all, their whole life. And would you prefer to come in twice a week to get an injection or sit half an hour or even 90 minutes in an infusion chair wasting your life? Or would you prefer to take a pill and come once a month for a checkup or once every other month? I think it's a clear answer as a patient what you would prefer to do. Absolutely,
but when you look at, and we're going to talk about this, adherence is a major factor when looking at oral agents. If you look at the studies done to date, adherence doesn't have a great track record even when we're talking about curative diseases like cancer. So I think oral adherence is one of the big barriers we need to conquer in that realm. I think from a clinician's perspective, they know when the patient goes in the chair and intravenous therapy is given, they know the patient's received the therapy, they're done, they're going to come back for another cycle or another day of therapy, and they know the patient's got the drug on board. Whereas with the oral oncolytics, we're really relying on the patient to make sure that they take those drugs appropriately.
When I was in medical school, we all heard, I'm sure we've all heard this study. You've heard this study. They gave placebos to medical students. They'd take one pill a day for a year. And they didn't tell them anything more than that. At the end, they collected the residual pills. Yeah. And approximately, a third of those pills were untaken. And that's with motivated medical students.
Yeah.
And, and that weren't curing anything.
Right.
And here we've got cancer. It's important that you do this, and you do it right.
Right, and even taking it wrong can be harmful.
Absolutely.
Not only just not helpful, but it can be harmful in cancer. And you have to use ways, and you have to educate your patient, and everybody has their own ways, but we always make a calendar for every single patient because oral oncolytics are part of every regimen that we give in multiple myeloma. So you have to make a calendar and write on every day when to take the pill, and they put it on their fridge, and that's how they remember to take it. And most of the time it works, sometimes that doesn't even work.
Right, what's more interesting because now every single new drug that's coming is going to be linked to a specific companion diagnostic, a specific target. We're doing personalized medicine now for most of our patients. So, of course, as the patient feels better and the treatment is actually working, then you get used to it and say, oh, maybe I don't need it anymore, maybe I can skip this day. So I think it's important to have that communication and education for all.
I checked my blood pressure and it's normal. So now I can stop my hypertension.
Exactly, that's the rationale, right? So that's how we do it.